Welcome everyone to this, our final day of Psychological Professions Week. I'm Maggie Rosario, Chair of the Psychological Professions Network in the East of England. I'm a clinical lead for Hertfordshire Partnerships NHS Trust in our IAPT services and a lecturer at the University of East Anglia. So, to our session entitled, How Can We Benefit from the Use of Measures in Psychological Therapies? By this title, we're really thinking particularly about the use of questionnaires in treatment, primarily to measure symptoms, difficulties, problems generally, outcomes from therapy, and movement to goals. I'm really pleased to be joined today by my co-chair, expert by experience, Paul Edwards. Paul sits on the IAPT National Expert Advisory Group with David Clark, amongst others, and is a lived experience advisor with the British Association of Behavioural and Cognitive Psychotherapies. He also speaks at a number of universities for their psychological wellbeing practitioner and high-intensity training courses. Welcome, Paul.
Hi, good morning.
We're also joined today by David Clark in pre-recorded form, by Alison Brabham, Emma Warnock-Parks and Tim Clark. First, some housekeeping. We'd love to hear from you, so please post your questions and comments in the Slido window on the right. If your question is directed to a particular speaker, please tell us who. For technical issues, please contact the email address webcasting@firstsightmedia.co.uk. The session is being recorded, so if you don't want your name to appear, please post anonymously. There's more information at the end about how to access materials and your attendance certificate and so on. This session is brought to you under the Transform and Innovate planet of our vision for the psychological professions. And what particularly stood out for me of these commitments, that we will use our evidence and expertise boldly to improve what we do. Particularly relevant are these statements about reporting meaningful progress in recovery and quality of life and tackling inequality of outcomes. Measures can really help us to do this. Here is a short film about our vision.
We know. You've seen many a vision come and go. We're trying to do something different here. In 2020, we went on a journey to co-create a more impactful and unified future for the 12 psychological professions so that we can deliver the best possible care and support for everyone in our communities. We had over 1,800 people coming together to share over 12,000 ideas, comments and votes about our vision for the future of the psychological professions and the commitments we must all make to achieve our visionary goals. A vision for the psychological professions. To transform lives and communities by extending and embedding psychological knowledge and practice across the whole of health and care. Here are just some of the commitments. Transform and innovate. Be flexible, brave, and open-minded in adapting our methods to meet changing needs. Tackle inequality of outcomes. Speak up, challenge, lead, and support each other to deliver our vision. Now, we want to make this vision real. We want to bring it down from these visionary planets to our blue and green planet Earth and connect it with everyday life. We are calling this process the Intergalactic Bridge. Over the next few months, join us in creating the Intergalactic Bridge. Tell us what's been working for you and your ideas on how to make this real. We'd love to hear from you.
Great, so today's session, we have loads to share with you today, and we hope that you'll share your thoughts and comments and questions with us. Paul is going to give his individual and thought-provoking experience of measures in therapy. David Clark will talk about the power of outcome measures as a lever for change at a service and national level. Alison Bradburn will be presenting on the use of measures with people with severe mental health problems. Emma Warnock-Parks will be demonstrating with a fantastic role play how to use measures responsively to tailor therapy and improve outcomes. And Tim Clark, with a little help from me at the end, will be considering outcome measurement in child and adolescent mental health services with reference to our East of England region. So without further ado, let me hand you over properly to Paul. Before we start, Paul, we thought it would be helpful to let our audience know that as part of the background for your story, you will be making reference to witnessing online harm to children. If this is something that holds particular meaning for you, then you may wish to take a few moments away from the presentation until the end of the next slide, CBT and me. Paul, am I right in understanding that you've had a course of cognitive behavioural therapy? Perhaps you could tell us something about what brought you to treatment.
Morning, everybody, and thank you for letting me speak. Yes, Maggie, I was working as a detective investigating major crime and was involved in an FBI-led worldwide paedophile investigation. Because of some of the work that I was involved in, requested by the Court of Appeal, I was required to watch a large amount of the most severe and explicit child abuse videos. And having already been involved in that investigation for some time with the group, I knew what their thoughts were in relation to when they were watching these videos. So having to view this material intensively alone in a small room gave rise to many intrusive thoughts, which in turn made me question myself. And I held the belief then that I was a paedophile and watching the videos for pleasure rather than to gain the evidence. Obviously, this was unacceptable to me, which consequently led to a breakdown and me being diagnosed with PTSD when that was my first experience of CBT in 2009. But interestingly, I was not honest with myself, therefore not honest with my therapist, and it basically just kept me on the hamster wheel of breakdowns until I was forced to retire from the police in 2016. When again I required a lot of help. But the benefit was at this point I finally became honest with everybody.
Paul, thank you so much for sharing that. I'm really sorry that you had that experience. Now this looks like a really important slide. Would you like to explain it to us?
Yeah, I think it's important for me to establish as a patient what the measures have been completed for. A patient, for me, will talk about goals or even getting their life back, not about measures or outcomes. These are clinical terms, I believe. I'm not a number and neither should I be. I'm an individual and it's my life I want to improve. A number to me does not mean improvement, because otherwise all I need to do is tick a lower number and score lower. But for me, I find that they really are a good indication of how my goals in various areas may be achieved or not. And that is important to the clinicians to be able to judge alongside what the patient is feeling and actually saying. I honestly do believe that therapists need to make measures relevant to the client and to the treatment and show how you've used the measures to shape what we are working on together and tie them into the goals. Using the measures can really help someone structure their experiences and enables them to talk about all aspects. So assisting in not having something getting missed.
I think that's a really good point. Certainly also about making the measures meaningful. I think your next slide reflects something you told me about the importance of location.
Yeah, first thing that I want from a therapist is engagement. I want them to look pleased to see me. that I'm the most important person in this room right now. Give me, as I call them, smiley eyes, engaging eyes. Completing the measures with honesty is important to the patient. So the therapist creating an environment where this can happen is very important. I will have spent many time thinking about my experience and need an environment where I can open up about that. I've recently entered therapy again, and because of intrusive thoughts with my PTSD, and I'm very pleased that because of the pandemic and also because of the use in technology, we can now complete these measures online. This has really helped me enormously, as I don't feel now that I'm sitting in a time-constrained exam at the start or end of every session. And it's helped me reflect more honesty on my answers, and therefore link them to my emotions and goals. I don't feel the need that I am just being overlooked and I just need to improve my scores. So as therapists, I'd love you to go away and give yourself 2 minutes to complete the measures. See how much pressure you feel. Then sit and do it with a coffee on your laptop with no time constraints. And I hope that you will get a far more fulfilling answer. Not only as a therapist will you seen these before, then you'll seen them before the session, and it could actually influence and give you a better session rather than just winging it at the last minute, because what you're seeing with those measures is not what you were expecting to see when you were preparing the session.
I couldn't agree more, Paul. It's been through discussing with you that I've really started to understand about the different pressures about completing measures and how to make the most of session time.
That's
In this
excellent.
next slide, I think you go on to talk about what's important to you and how to use the measures to help there.
Yeah, I mean, this slide actually looks like a real strange juxtaposition when you first look at it. What do you want? What do I want? Really, for me, the end game is just the same. And it's just how we use those measures and outcomes during treatment individually as therapists and patients to hopefully discharge, or as I would say, seeing my achievements being reached and my goals, and also giving me a toolbox to use in the future of techniques. So for me, it's purely down to, as well, a matter of semantics and language we use. As a professional, being in the police, it's really, really easy to get caught up with acronyms and jargon. But remembering that the patient probably hasn't completed the same courses and hasn't got the same terminology as you, so might not understand what they mean. So again, for me, it's important that a therapist doesn't make any assumption as to the patient. It's not the measures on their own that are important. It's the implications. It's how they shape the treatment, how they're used individually, how they reflect my goals on the route map that you've got for my recovery. Measures are important as well for planning for the session. So the therapist is not just acting off the cuff, but also we can see that we might need to work together on things as we meet. And then the measures can be adjusted as the treatment goes. And that's the goal ultimately. Your measures, my recovery.
Certainly your passion for measures comes through. In this next slide, why didn't you tell us about it?
Yeah, I think that when I was putting together this and we were talking about it really is about my curiosity, about my own experience when using the measures. But to me, it's also very important about how the therapist talks about the scores. Really is important. I really hate it if somebody says, "Oh, you're a 17 now," because it just means nothing. It just means nothing. I want people to be able to use those scores as a springboard for the conversations. Oh, I can see your scores have come down. But has something happened? How can you make sense of that? So to me, it's about being collaborative. You'll give us the tools, but we have to do the work. We're all individuals with different feelings of what recovery is to us. Recovery to me is not a 6 on a piece of paper. It's an emotion and it's a goal. But I do honestly feel that we can tie that emotion into the scores to understand our lives. But we have to be able to link these honestly so we can feel them. So that takes a lot of work from us with the help of yourselves. It needs explaining and it does take practice. It really does. I lied many, many, many times to stop treatment, to keep my job, because I thought if I lowered the score, the emotion would follow. The other way around, really. True answers during therapy then didn't add up to the scores. And luckily, sometimes it was picked up, but other times it wasn't. Every client patient will have a different level of interest in the measures, but explore those interests and tailor the information you need to give to reflect this. Some clients, patients will only want a general overview. Some people really want to explore and understand the measures and what is happening over time, which I'm one.
Paul, I really like your point about people being different in what works for them. Speaking with you has really helped me to consider the importance of flexibility in approach, also about working together and sharing decisions. Let's move to the next slide. Do go ahead.
Yeah, again, this is just about the important fact of proper communication and collaboration, the therapeutic relationship. Although you're coming from different directions, ensuring what the patient has achieved is, to me, the most important things. It shows to me that the goals and emotions are the most important thing to me. But you'll have a matrix of data that you have used to help me achieve those goals. So please don't congratulate me on being a 25 when I started as a 55, any more than I'd like to say as you walk through the door, oh, you're a 1 out of 10 or a 5 out of 10, for example, because they're meaningless in isolation. But please do feel free to ask me how you think I progressed during treatment. And if by achieving those goals that it's improved my life and improved those scores, explain that. Feel free to then say that it has been reflected in the measures. And because you've completed them honestly, we can see this as a reflection of the hard work you've done and how it's linked up. A question a patient may ask themselves is, what if I've got the numbers wrong and I don't make the best out of therapy? What if I'm misleading my therapist, honestly, or by mistake? What if I don't get better and my therapist thinks I'm not trying? What if I'm not getting better and it means I might never get better and my therapist feels bad about themselves? Or what about if my therapist is trying to put me in a box, like on a conveyor belt, and not seeing me as an individual and I'm just a number? For me, this is not a reason not to use measures. It really is a reason to think about how you use them and the benefits they can give you.
I know this last slide is important to you. Would you like to share your thoughts?
Yeah, it's not much to say really, but when I heard this song, which was written by Robbie Williams to his daughter about his own mental health struggles, it really did make me think of my journey and also the relationship with my children and family. I know having entered therapy again, unfortunately, because of the complexity of the issues that I've got, my journey will never end, which really proved to me that I can ask for help again. But I really am in a fantastic place in my life, and hope that because of the fact I've entered therapy again and I can continue working as a lived experience advisor and speaker to help both professionals and the public, accepting that we can all suffer in our lives, but there are fantastic tools out there to make our lives fulfilling. After all, recovery by very definition can mean a return to a previous state. But my thoughts are in mental health, it's exactly what we don't want to do. We don't want to be on that hamster wheel because we'll keep rotating. So for me, we want to return to an improved and more fulfilling and understanding version of ourselves. So ultimately, I guess, and the place I want to be.
Paul, thank you so much for being willing to share your experience and thoughts. I've so enjoyed this work with you. I think it's over to you now to introduce someone that you've worked with quite a bit, I think, David Clark.
Yeah, thank you. I'm honoured to have met David on a number of occasions and worked with him. And we now have a presentation made by Professor David Clark. It is recorded last week because unfortunately he's in the States and in a different time zone. So I hope you enjoy this recording.
Shall we play the recording?
Good morning. My name is David Clark, and it's a pleasure to join you today to talk about how outcome monitoring helps services to improve the support they provide to their patients. There are really three big benefits to outcome monitoring. The first is that it helps guide a course of therapy, and Emma Warnock-Parks is going to talk about that in today's session. It also gives patients a voice and facilitates the therapeutic relationship, and Paul Edwards is going to talk about that. And lastly, it helps services to improve and releases extra investment for mental health services. And I'm going to talk about that. And I'm going to do it particularly by illustrating it with the case example of the Improving Access to Psychological Therapies, or IAT program. This program really came about by lobbying by an economist, Richard Layard, and a clinician, myself. And the arguments we put to the government of the day are summarized in our book, Thrive, The Power of Psychological Therapies, if you'd like to look at them in detail. But broadly speaking, it said that if psychological therapies are implemented at scale, it will be an economic no-brainer because the benefits to society in terms of other savings will more than cover the cost. That argument was accepted by the governments of the day, and the national rollout of the IAP program was announced by Alan Johnson on World Mental Health Day in 2017. And part of the announcement, because it was money for 3 years, was to say that that money would lead to 900,000 more people being treated, and 450,000 of them would recover, so a sort of 50% recovery rate, as expected by NICE guidelines. So this was really based on the suggestion that if we could implement the treatments well, the same level as in the clinical trials, we should get rather similar outcomes. So about 1 in 2 people fully recovering from their anxiety and depression, and about 7 in 10 show marked improvement. Well, obviously, with a commitment like that, it was very important to collect data to see whether we were able to achieve those outcomes. And by the end of the first year of the program, we were collecting outcome data on 92% of everyone who had a course of treatment. That's 2 or more sessions. So what did the data show? Well, on this graph, you can see the red line is that 50% target. And the first thing you'll notice is that we were nowhere near it at the start of the program, just 36% recovery. And if we hadn't had outcome monitoring in place, that's probably where we would still be 13 years later. But thankfully, because we had outcome monitoring in place, we were able to detect that. And in particular, we were also able to see that while on average we were well below what we hoped for, there were some services that were doing very well. And we could study what are the sort of features of those services that were doing well and learn from that and feed that back into the system. And as you can see, that led to steady improvement in outcomes. And for the last 5 years, we've been above that 50% recovery rate very consistently. We're currently at 52%. What does this mean to patients? Well, it means an awful lot. It means that currently each year, more than 100,000 extra patients are recovering than would have happened if we had stayed at the sort of level of outcomes that we started with, which we would have done if we weren't studying the data and improving. So what are some of the things that we've learned from the data? Well, it's an enormous amount. And if you'd like to see the full story, you'll see it in the Improving Access to Psychological Therapies manual that you can download from the NHS England website. I'm just going to mention a few key findings. The first was, is it really important to give patients the NICE recommended treatment, which is a key idea behind IAPT? And I think that was controversial at the start. And we did have a fair amount of examples where patients were being given a treatment that wasn't fully recommended by NICE. And so we were able to look at, did that make a difference? And it did. So if you take depression, NICE recommends CBT, but it also recommends counseling. And we found that was right, that our patients did just as well with counseling as they did with CBT. In generalized anxiety disorder, many of my counseling friends say that they think they do very well with generalized anxiety disorder. And it turned out they were right, about 48% of patients recovered. However, NICE doesn't recommend counseling for GAD, it just recommends CBT. And it turned out that was also right, because with CBT, we had a substantially higher recovery rate, 58%. So services are now much more NICE compliant than they were at the beginning because of that finding. What are some of the other features of services that we found were associated with very good outcomes, all of which have now been changed as a consequence? Well, the first is to do with the assessment. In those services where almost everyone had what we call a problem descriptor, so the assessment had resulted with identifying specific problems to work on, like PTSD or depression or social anxiety, the outcomes were better. How long you wait to the start of treatment was important. In those services where on average you waited less than 6 weeks, you had better outcomes than those where essentially the same treatment was being offered, but the wait to start treatment was longer. There seems to be a window of opportunity to get going on psychological therapies. And as a consequence, all services have reduced their waiting times and get better outcomes as a consequence. Those services which had high DNA rates also tended to have poorer overall outcomes. This is an easy problem to fix. The services adopted SMS text messaging to remind patients of their appointments. DNA rates dropped considerably and outcomes improved. It's a step care model, and it turned out that making good use of step care is important. So those people who don't recover at low intensity need to be stepped up promptly to high intensity. And those services that did that got the best results. And lastly, just like medications, there's a dose response effect. Those services that gave a higher average number of sessions got better overall outcomes. At the start of the program, the average number of sessions was round about 6. But in the light of these findings, services have been gradually increasing their average number of sessions, and they're currently at 8. However, we do think we can go further with that. And you see this from an analysis of the last 1 million patients treated in IAPT. And this is the recovery rate and the reliable improvement rate as a function of how many sessions people have had before they're discharged. And you can see that if you have 6, 7, or 8 sessions, you've got very high recovery rates, 60 to 65%, and very high reliable improvement rates. But for those people who don't recover with that number of sessions, if you give them a few more before they're discharged, you see they're still getting really a good chance of recovering and improving. And that continues up into the 20s, really. So we would like to further increase the average number of sessions, and this data is allowing us to bid for funding for that. So it really takes us on to one of the other big benefits of collecting outcome data, which is releasing investment for mental health. So at the start of the IAP program, announced by the Labour administration, the budget was £33 million per year, with an increase in the next 3 years. At the end of that 3-year period, we had a change of government to the coalition. Our outcomes were certainly not at the 50% that was promised, but the coalition could see that we were improving and that we were collecting the data so they would know what they were buying from their money. And so they invested a substantial additional sum in expanding IAPs. When we shifted to a Conservative administration under Theresa May, the government again invested to further expand the services. They could see that it was continuing to get good outcomes and improving, and the current administration has done the same. So the budget has moved to £670 million per annum, and many more people are having treatment as a consequence. So if data is so critical, how do you collect it, and how do you get pretty complete data? Well, the first thing is you need to make data entry easy for patients. And nowadays, we're mainly using web portals and mobile phone entry. So people aren't having to fill in questionnaires on paper. They can just do it on their mobile phone. Also, that can automatically go into the IT system. There's no sort of manual entry in the services. And that generates graphs for patients to look at, to see their progress, for therapists to view, and also for their supervisors to view. In order to get complete data, you do need to give measures each time someone is seen, because often people will finish therapy at a slightly different time to what you're anticipating. And if you just try and go do the beginning and end, you'll miss that data. It is very important that the data collection is not a burden that interferes with therapy. So we ask patients to fill in the questionnaires before a therapy session starts. So you're not wasting valuable therapy time completing questionnaires. And of course, we train the therapists in how to use the outcome questionnaires to guide therapy. And you'll see that in Emma Warnock-Parks's questionnaire. So if the data questionnaires have been completed before the session, the therapist can look at them just before the patient comes into the room and then use that information to help guide the session. It is helpful to report how services as a whole do quite early on in a program, because that means you can get on and learn from variability. And we found that the best reporting is one which also encourages complete data using something we call smart metrics, where if you're counting, say, recovery or reliable improvement, the percentage value will be the number of people that you've actually got data on and have shown that they've changed in a predicted way, divided by the total number of people that you treated, irrespective of whether you got the data. This means there's no real incentive not to collect the data. And lastly, clinical leadership in services with outcome monitoring is absolutely crucial. You need to have a clinical leader who is not looking at the data in a sort of punitive, very performance-focused way, but is looking at it in a very inquisitive way in which the whole team is coming together to see what are the patients we're doing really well with, and to feel really good about that, but also what are the ones that are still a challenge for us, and are there ideas we can have as a group that might move things forward for that group. So really take everyone on a journey of exploration with the data, rather than a sort of punitive performance mode, which, as all of people in the psychological professions know, is a totally hopeless way of behaving. So thank you very much.
Thank you, Dave. Now, I'm so pleased to be able to hand you over to Dr. Alison Brabham. Alison is Clinical Advisor to the Adult Mental Health Programme for NHS England and Improvement. She is a clinical lead for community transformation and visiting professor at Trinity College Dublin. Alison, thank you so much for joining us. I'll now hand over to you.
And thank you, Maggie. And thank you for giving me the opportunity to speak this morning. I'm going to be really repeating a lot of what we've already heard from Paul and from David, I've got to say. But the reason I'm here this morning is really to talk about routine outcome monitoring with people who present with severe mental health problems, and to really think about what their experiences are and what are the challenges of working with this particular client group. So if we can move to the next slide, that's great. So in terms of, I suppose, as we've heard already, there are multiple benefits for outcome monitoring. I mean, I think we've heard it from David, we've heard it from Paul. I mean, I'm not going to spend my whole 12 minutes going through this, but we know that outcomes really do help us to recognise the impact of our individual interventions as well as clinical services, as well as also sometimes highlighting that we're not having a great deal of impact. So sometimes what it will do, as David said, is show where we need to be kind of working a bit harder, or identifying where what we're doing isn't really doing what we want it to do. And that should actually really help us in terms of improve the effectiveness of interventions. It also, I've got to say, in terms of a key area, is that if we're doing outcome monitoring meaningfully, it really should help us to work more collaboratively with people and to really understand their needs and ensure that we are working on the things that are important to them. So this is about really increasing clinician and service user collaboration. And as I say, making sure that what we're doing in terms of goals is about shared decision making, making sure we're not just doing what the therapist thinks best, but really focusing on what the service user feels is important. And as we've heard from David just now as well, we also, in terms of really getting investment in psychological therapies, what outcome monitoring can do is demonstrate the impact and value on psychological therapies to all of our key stakeholders. And there are, I mean, service users are obviously the key stakeholders, but the people who are paying for services also want to know that they're getting some value for money as well. So if we move to the next slide. So I'm going to talk a little bit this morning about IAPT SMI, and IAPT stands for Improving Access to Psychological Therapies for people with severe mental health problems. And one of the kind of key elements of IAPT SMI was, first of all, to see what the kind of how we overcome the key challenges to improving access to psychological therapies for people with a diagnosis of psychosis, bipolar disorder, and personality disorder. But within that, there was a key objective, which was to really understand the challenges of identifying and implementing meaningful patient-reported outcome measures. So if we move to the next slide. So just to give you a little bit of background, so IAPT SMI was very different from IAPT, the adult IAPT program that David described. It really focused on a number of demonstration sites across England that were delivering psychological therapies to people with a diagnosis of psychosis, bipolar disorder, and personality disorder, as I've said. Within that, with each kind of different client group, so those with psychosis, those with bipolar, and those with a diagnosis of personality disorder, there were specific outcome measures that we used for different kind of populations. And that was because each of those populations identified different things that were important to them. Some of those outcomes were collected each session, and others were collected less frequently. If we move to the next slide. And I've got to say that when we first suggested we were going to use a set of outcomes within IAPT SMI, we had a lot of challenge. People said, oh, this isn't going to work. People with more complex mental health aren't going to want to complete outcome measures. It's going to get in the way of the therapeutic relationship. People will disengage. They'll just not complete the measures. You'll have huge DNA rates or do not attend. So people will stop coming to therapy. So the first thing was to really find out, is this true? Is this something that service users benefit from? Do they have a, do they see it positively or not? And I suppose we started getting some clues of this in terms of our completion rates. So in terms of paired scores, so this is when we talk about paired scores, for those of you who aren't into outcome measures. A paired score is a kind of a measure that you take at the start and a measure you take later on to see if there's been any kind of major changes. So, and that you need those two paired scores to first of all see if you've had any impact. When it came to IAPT SMI, in terms of those paired scores, it varied between the sites, and it varied between 67% of people having of the population having a paired score up to 98%. So this was definitely giving us a clue that this wasn't something that people were objecting to. The other thing we found out was that it was if you did your outcome measuring every session, then you tended to get much higher levels of those paired scores. But also, and it's something that we heard from Paul earlier, in terms of outcome measurement, what is absolutely essential is that you are measuring something that is meaningful and that is relevant to service users, to the person who you're actually working with. It's pointless just focusing on something that's important to the therapist. That's not going to work. And what we heard a lot from people, our populations, is who we were working with, was it wasn't symptoms that they were interested in looking at. What they were interested in was personal recovery, was quality of life measures. And so that's what we were measuring. We also, as David said, we found that, as it makes sense, is that really measures had to be as easy as possible to collect. So short measures, you didn't want huge long questionnaires. If you could use electronic means, for example, that would help. But both in terms of service user burden and clinician burden, it needed to be something that was easy to do. So if we move to the next slide. And of course, one of the things for us that was absolutely essential was to find out, did service users actually have a positive experience of using measures? Was this something that they felt was beneficial, or did it feel like they were just being asked to do it because the therapist thought it was important and it had no kind of positive impact on them? So a team from South London and Maudsley Trust, led by Miriam Fornells-Ambrogio, they basically did some work to ask service users within their demonstrator site what their experience was of actually collecting outcomes. So if we move to the next slide. And what we found, or what they found, was that the majority of people kind of saw outcome measurement as helpful. So all of them were basically rating, everyone who they asked rated how they saw their outcome measurement on a scale of 0 to 10, where 0 was kind of extremely unhelpful and 10 was extremely helpful. 5 was like neither helpful or not helpful, neither helpful or unhelpful. And the mean score from the group was about 6.7 to 7. So what was also interesting was that the majority, over 90% of people, rated outcome measurement as either neutral or helpful. I think 72% of the group gave outcome measurement a score of 6 or more. We also heard earlier from Paul that something about outcome measurement really helping to encourage people and finding it helpful when you actually see that you're kind of moving towards your goal. However, on the converse of that was that there were people who just felt like they weren't making progress, and they found it discouraging when outcomes were showing that there wasn't any kind of progress. So we need to be mindful of that, and therapists need to be having those discussions. In terms of themes that emerged, people felt that kind of, in particularly, they felt like they were listened to and understood by completing measures. There was much more opportunity, as I say, for discussing what was important to the service user. So people valued that opportunity to reflect, to express their feelings and track progress towards their goals. But I think the other thing is we have to just really recognise that outcome measurement is an individual process. Not everyone does feel it is as really kind of helpful. And I think we need to be asking service users about their experiences of completing measures. What's it like? Is there anything we could improve? And for those people who aren't finding it helpful, we need to think about making it kind of adapt to their needs. So can we reduce the length of the tool or the tools we're using? Could we reduce the frequency of monitoring if someone isn't seeing this as helpful? In terms of that evaluation that was done at SLAM, interesting enough, there was a bit of a trend that we found that younger service users and those with high severity of general symptoms or lower functioning were less likely to be satisfied with outcome monitoring. It wasn't directly related to psychotic experiences, however. It was more of those general symptoms. But again, just to keep that in mind. If we move to the next slide, and I suppose it's just about thinking about what the challenges are if we are going to do outcome measurement meaningfully. And I think the first thing is about getting the most, really having those focus groups when you're selecting your measures, and make sure that what you are measuring is important to the person who you're asking about the impact of therapy. So you need to obviously think about something that's psychometrically sound and that's sensitive to change. If people can't see any changes being made, then they're going to be discouraged, as I said. We also need to really think about the culture of mental health services and getting staff buy-in at all levels of the organisation by really getting people at all levels, all the stakeholders to understand the benefits of outcome monitoring. As we heard again from David, there's something about staff competence, and staff really do want training in routine outcome measurement. We need to be collecting outcomes in a clinically meaningful way. We hear lots of bad examples at times in terms of people just handing out questionnaires and then sticking them in the back of the notes. Not having those discussions that we heard from Paul are so important. The person, this is something that's important to them. Don't just treat this as data. We've heard that outcome measurement needs to be quick and simple. And we need to give people choice in terms of how they complete outcomes. Yes, it's great to have apps available, but some people were quite suspicious of electronic means. So we also need to make sure people have got access to paper and pencil kind of tools as well. We need to be thinking about, as I say, an individual. We need to make sure that therapists, service users and everyone can get access to kind of inputting data and also looking at their results. So we need to make sure we've got IT systems that are kind of suitable and that there's a real kind of easy way of reporting and displaying your results so people can see graphs and see how things are progressing. And finally, I think that we heard this again from David in terms of really we need leadership who are inquisitive and who are supportive, and there cannot be a message out there that outcome measurement is about kind of a stick to punish services or to kind of measure therapist competence. This is really about improving outcomes for service users and about improving their experiences. So I'm aware I've gone over, so I'm going to shut up now, and I think we're over to Emma.
Thank you for that, Alison. Very insightful and yeah, very good. We now have a video from Emma Warnock-Parks, who is a research clinical psychologist in Oxford, showing us the importance of measures in shaping individual treatment. So over to Emma's video.
Welcome everybody. I'm Emma and I'm a psychologist working at the Oxford Centre for Anxiety Disorders and Trauma, and I'm so pleased to be here today to talk about this important topic of using questionnaires to guide treatment and how this really can improve our outcomes. I'd like to make this quite an engaging session. So I'd like all of us, if you don't mind, to take a moment to ask yourself a couple of questions and just make a note of your private responses, whether you're somebody who is having treatment yourself, whether you're a practitioner or you're a supervisor. And ask yourself, how much do I look at questionnaires each week to guide therapy or supervision? And answer that whether that's never, sometimes, often, or always. Then I'd like to ask you, how strongly do I believe this statement that reviewing questionnaires weekly improves therapy outcomes? And think about how much you believe that on a scale of 0 to 100%. If 0 is I don't believe it at all, and 100% is I believe it completely. Where do you fall roughly on that scale? Just make a note of that. If I think about my ratings to these questions right now, they would be very high. But if I go back in time to when I started as a psychologist, I didn't use questionnaires nearly as closely as I do today. And I can see that that was related to my belief in how helpful I think they are. I think back then I saw them as being a bit of a burden for people, and I didn't see how essential they are to guide treatment and how much we might miss without them. So in this talk, I'm hoping to cover how questionnaires are essential at each stage of treatment. At the first stage of mapping out the problem together that the person's bringing for treatment. At the second stage of planning key interventions we need to do to help the person overcome the problem. And at the third stage of evaluating how well those interventions have worked and then going back to our roadmap to see where we need to go next in therapy. So let's start firstly by looking a bit closer at how questionnaires help us map out the problem together, or the problems in therapy. Now, therapy, and CBT as an example, relies on having a really good roadmap of the person's difficulties, okay? We need to know what all the key processes are, the thoughts, the behaviors, the biases that are keeping the distress going, so that we can plan careful interventions to target them. At the start of treatment, this can be like doing a jigsaw puzzle together, okay? It can be quite challenging to find all the key pieces. As you might see in this image here of David Clark mapping out the roadmap of a person's social anxiety, there are often lots of pieces of the puzzle to find. And using questionnaires is absolutely essential at this stage of treatment. Because if we have a roadmap for therapy that is full of gaps, it's really going to slow down the progress in treatment and could actually limit the outcomes that we can get. When mapping the problem at the start of treatment, there are a number of challenges. It can be really difficult to identify our thoughts, our feelings and behaviours when we're in a state of distress. For many of us, these problems have been around for many years, and that can make it harder to spot things. There may also be lots of thoughts and behaviours to spot, not just one or two, and some may be difficult to talk about for a variety of reasons. We may feel embarrassed, be a bit ashamed of some of our thoughts and behaviours. We may have a fear of becoming emotional if we talk about these things, or saying certain thoughts aloud might mean we hold back. So questionnaires used collaboratively to prompt discussion can be a great way to map out the problem together and make sure we're not missing anything key. Now let's take a closer look at how questionnaires can help us plan interventions and identify any roadblocks to recovery. To do this, I'm going to give an example of somebody who is having treatment by one of my supervisees, and we'll call her Fatima. So Fatima was having cognitive therapy for social anxiety, and she had a number of key fears that she and the therapist had already identified. That she would look anxious in social situations, look sweaty, come across as boring, weird, stupid, that people would stare at her. Okay. And they had been tracking her progress in treatment on a measure of social anxiety symptoms, the SPIN, the social phobia inventory. And what they noticed over the first 6 sessions, as you can see in this graph here, that things had started to improve quite early on, quite nicely. And then her social anxiety had got a bit stuck. There hadn't been so much improvement in sessions 4, 5, and 6. So they decided to look a bit more closely at the roadmap again together. And they looked back at their roadmap, and also the questionnaires were explored. And particularly some process measures, so a questionnaire of the thoughts she was having, the social cognitions questionnaire, and her safety behaviours, the social behaviours questionnaire, to help identify any roadblocks to treatment. And looking quite closely at these questionnaires was key in guiding the plan to treatment. So what they were able to identify by looking at the thoughts questionnaire, which is a list of thoughts people often have in social situations, was that she still had a very high belief at session 6 that she was being stared at 90%, okay? They hadn't actually targeted this yet in treatment. And on the safety behaviours questionnaire, they were able to see that she was always doing 2 key things related to that fear. She was hiding her face and often avoiding eye contact in social situations. So what she was doing whenever she left the house or went into a social situation was that she was looking down. Okay, hiding her face. And this is a big problem in social anxiety because it can really keep the fears going. Because actually, if you're going into a social situation looking down, what you're unable to see is how the other people around you are actually responding to you. You're just left with your feelings that you're coming across in this very negative way. You're unable to see that others may be responding to you as if you're totally acceptable. So this discovery led on to a really important session where they were able to test out this fear together in a key experiment, a very brave experiment. So Fatima, during a remote session, had her therapist on her headphones and her mobile phone and left her home, okay? And they did a little task together whereby she was able to walk into a busy high street and do what she usually did, have her head down, and bring on the feeling that she was being stared at. And her therapist encouraged her to make a prediction. How much did she feel people were staring at her? And she rated that at 80%. And then she did the very courageous thing of looking up and looking around her, as you see in the photo there at the bottom, and discovering that actually other people weren't staring at her, that she was really staring at herself, okay, that she was actually coming across acceptably to other people. A really key intervention there. This example is a great one to demonstrate our third key point, that evaluating interventions each session is really key. We see that in the graph here, where at session 6, that staring experiment happens. And then the following session, session 7, there's a lovely reduction in Fatima's social anxiety. She's feeling so much better in social situations. And we see that continuing then across the course of treatment. But we wouldn't have known that if we hadn't been tracking these things every week. Let's move on to 5 key tips for getting the most out of using measures. Firstly, we want to select the most relevant measures for the person's clinical problem that they're coming with. But I think also in tracking symptoms, but also those key processes that are keeping the problem going. Secondly, we all want to be on board with using measures. So let's discuss them from the start. Look at the measures we're going to be using, discuss the advantages, seeing them as a key tool to guiding the treatment together. Thirdly, where possible, we want to encourage people to complete measures outside of treatment, so it's not taking up time in the session, seeing it as a part of preparing for your treatment, a part of homework. Okay. Fourthly, we want to make sure, if possible, we can spend time looking at the measures before the session and identifying some potential targets we might want to discuss with the person and taking them to supervision as well. Finally, we want to discuss measures together every session and use them to guide the session plan. And I'll show a bit of video of doing that shortly. What we tend to find is that if measures are set up in this way, people find them helpful and acceptable to use in treatment. So in order to demonstrate a lot of what I've covered in this talk, I'd like to show a video role play of an extract from a CBT session for PTSD where my wonderful colleague, Leanne Jones, is playing the therapist and I am somebody who's been through a traumatic birth. And in this session, we're talking about the impact of the trauma. So just to say, if you're somebody who's been through this trauma, no details of the trauma are in the video, although you may choose not to watch it if you prefer. The therapist here has already looked at the measures prior to the session and now is discussing them with the person in treatment. So to make this more of an engaging exercise, I'd like you to try and note down as you're watching any key advantages you see to the session that using the questionnaires bring. The nightmares, the memories, they've been so much better since we did that work together last week.
Oh, that's brilliant. I'm so glad to hear that the work that we did last week has been really helpful for you. So should we make a plan for today's session? Is there anything in particular that you'd like to cover?
Nothing particular that comes to mind, no.
Well, I guess in that case, then, shall we pull up the questionnaires? And thank you so much for doing them. And we can go through them together, and that can give us a bit of an indication of what's been going on for you over the last week as well. Is that okay?
Sounds good.
So I'll pull them up now. So as you can see here with the PCL, which looks at some of the symptoms around PTSD, we can see there's been a big shift already. Scores have definitely come down around the memories and unwanted memories. So the work that we did last week seems to have really made a difference.
Yeah, the work we did last time, like both with the triggers, that then and now, but also like focusing on what I'm like bringing in what I know now. That really, I think that really helped. Like I haven't had any nightmares this week at all.
Wow, that's brilliant. We can definitely see some progress there.
Yeah.
That's really wonderful to hear. So we can actually see that on the scores as well. And as we scroll down as well, just to have a look at some of the scores here, I can see there that the scores are still slightly higher around some of these other points here on statement 11, having strong negative feelings such as fear, horror, anger or guilt or shame, loss of interest in activities, which seems to be quite high for you at the moment, and feeling distant or cut off from other people, and trouble experiencing positive feelings. I guess, have you been noticing that for yourself as well for this week? Kind of that a bit more of a lower mood there?
Yeah, it seems a bit strange in a way, doesn't it? That the memories have been better, but I think I have been feeling quite flat quite a bit over the week.
Yeah. So, yeah, thank you, Emma, for kind of mentioning that as well. And have you had any particular thoughts that have come to mind when you've been feeling low at all?
I haven't really noticed what's anything in particular. I don't know, just been feeling a bit cut off, I think, at times, a bit flat.
Yeah. Those definitely sound like some difficult feelings that you've been experiencing. And I guess sometimes it can be quite difficult to find out what those thoughts are. But we do have a questionnaire that kind of looks at some of those thoughts. So would it be all right to go through that together as well? Brilliant. So as we said, we've gone on to this other questionnaire, so the PTCI, which helps us just to identify some of those thoughts again together. And what I can already see is that there's definitely been a big shift already, and especially around some of the guilt that we've been working on within the sessions.
I've totally noticed that, actually, like the feeling guilty, which was a massive problem for me, wasn't it? Like that really helped. Some of the work you did with me, the pie chart we did, like it's really changed how I think about it.
That's really great to hear. I'm so glad that was helpful for you. And I guess what we can just highlight here is just there's a few there that kind of stand out a little bit more at the moment. So some thoughts of if people knew what had happened, they would look down on me. I feel different from other people because of my experience, and my life has been destroyed by the event. And it sounds like those are quite some difficult thoughts that you've been experiencing there. Emma, would it be all right for you just to tell me a little bit more of some of these about some of these thoughts that you've been having?
I think it's just really started to hit me that what we've missed out on is, you know, like what he's missed out on, having a mum that didn't have all this going on, you know. I think I feel a little bit ashamed, actually, that this is how I've been feeling for the first year of his life. This is the kind of mum I've been, you know.
Yeah. And it sounds like those have been really challenging thoughts that you've been having, especially over this week as well. And first of all, I really appreciate you sharing those thoughts with me. I was looking at some of the other questionnaires of how it affects how we behave as well. And it looks as though that there's been a bit more dwelling as well this week. Have you noticed that at all?
I think now you say that, I probably have been going over it a bit at times.
Yeah. And once again, thank you for sharing that with me, because it sounds like that's definitely had an impact on how you've been feeling as well this week. Do you think that kind of maybe even thinking a little bit more about this and the role that dwelling plays on this would be helpful to think about for the rest of our session? We could focus on that for our session.
Yeah, actually, I do think that would be helpful. Thank you.
Brilliant. Okay.
What advantages did you spot? Feel free to put some things in the chat, but hopefully some of the highlights were that using a very problem-specific measure of PTSD and those process measures, looking at thoughts and behaviours, really helped to not only track the improvement in treatment that really fitted with the person's experience, but to reinforce the progress that was being made in treatment and to really help the person see what particularly in the treatment is helpful, really, really important, but also helped them spot problems that may otherwise have been missed, okay, and revealed some really key therapy targets that were going to be important in that session, and also helped overcome a potential block there, which was shame getting in the way of the person disclosing, okay. Hopefully what you saw in that video and in the talk today is that without questionnaires, we may miss half of the picture, that these questionnaires are so key in helping guide the treatment we're doing with people to improve our outcomes. I would just like to mention that for any therapists watching, there's some wonderful resources on the oxcadresources.com website, including all the questionnaires I've shown and talked about here today, and other videos, longer videos on using questionnaires in treatment, and much, much more. Before we finish up today, I'd like you just to ask yourself the following question again. How strongly do I believe the statement that reviewing questionnaires weekly improves therapy outcomes? And to rate that again on a 0 to 100% scale. If 0 is not at all and 100 is completely. Just think roughly where am I on that scale and make a note of it. And then spend a moment, if you were here at the start and you made a rating at the start, just to compare your ratings. Has there been any small changes perhaps from this talk? If so, wonderful. But if not, don't worry, because the greatest changes come from action, from trying things out for ourselves. That's what I've discovered over the years of using questionnaires much more closely, how key they are. You only really sometimes really know that from discovering it for yourself. So therefore, what I'd like to ask you to do as you finish up today is to take a moment just to write down any key take-home points, but also anything you might try differently, whether you're somebody having your own treatment, a practitioner, a supervisor, or a trainer as well, because it's absolutely essential that we train people well to use questionnaires to guide treatment. Thank you so much for joining and listening, and do post any questions that you have for me. Questionnaires on the brain. Thank you.
Excellent. Thank you so much, Emma, for such an insightful recording. Thank you so much. And you're joining us for questions later if you have time. That's brilliant. Okay, so I'm going to hand you over to Dr. Tim Clark, who's a principal research clinical psychologist for the Norfolk and Waveney Child, Family and Young People's Care Group. He is an advisor from the East of England Clinical Network for NHS E&I and a children and young people's mental health advisor with Norfolk and Waveney Clinical Commissioning Group. Tim, welcome. Let me hand over to you.
Thanks, Maggie. Thanks everyone so much for the discussion so far. You've made my job rather easy actually, because many of the messages that I wanted to convey have already been talked about. So we will skip over some parts where there's duplication. First of all, just a bit of an acronym buster. So when I slip into acronyms, which I probably will, ROMS refers to routine outcome measures, CAMS refers to children and adolescent mental health services, and CYP mental health is children and young people's mental health. From listening today, there's so much we can learn from IAP services. There's lots of overlap in terms of the benefits and the obstacles of implementing outcome measures. And actually, I would say that IAP services seem actually much further ahead, really, than most children and adolescent mental health services in the United Kingdom in terms of collecting paired outcome measures, integrating them clinically, and also the digital use of them. So I'm going to focus really more today on learning from implementation science and behaviour change models to really identify opportunities for us to improve our use of outcome measures. So we won't rehearse the conversations here today in terms of the benefits of outcomes, as that's already been aptly done. However, with all of these benefits as listed on your screen, studies have shown that treatment outcomes are measured in only 16 to 30% of clinical cases, which is particularly low, and we know that needs to increase given the benefits mentioned here today. To my surprise, there's also been lots and lots of literature and evidence and research papers in the topic of implementing routine outcome measures in children and young people's mental health services, which actually makes our job a bit easier. Together alongside that, in the east of England, we've been working with clinical children and people's mental health services using a survey approach and focus groups to identify what the barriers and facilitators are to implementing outcome measures in clinical practice. And what I've tried to do here is to theme what those barriers and facilitators are in children and people's mental health settings. So as we can see, barriers include things that have been mentioned today, really. So they can be considered as time consuming. There's a negative perceived value often and misuse of outcomes data. There's often a lack of administrative and managerial support, a lack of digital and electronic patient record functionality. Often they're not prioritized or integral to clinical models or clinical pathways. There can be poor completion use and they're not used for feedback. And often the culture of routine outcome measures can be negative, which of course then can breed negativity. However, we want to think forward and think more optimistically about how we can change this. So the facilitators that we really need to focus on include ongoing training and guidance related particularly to clinical utility, dedicated roles to support the implementation of outcome measures, particularly in the absence of good functioning digital systems. So some of our services have outcome measure administrators. We definitely, as in the case with IAPT, need improved digital and electronic patient record solutions with visual results during sessions. We need strong leadership and clinical leadership with shared staff vision and a good organizational culture. We need to consider the use of more brief session-by-session outcome measures within young people's mental health settings. We need tailored measures, so not a one-size-fits-all approach, which I think Paul spoke really eloquently about earlier. And we need to research the implementation of outcome measures early, and we need to do with clinicians rather than do to them. Thinking about a particular paper in a little bit more detail, this has been done by colleagues Holly Bear and others, and really thinks about a particular behaviour change model and very implementation science-driven approach of using the capability, opportunity and motivation model of behaviour and applying that to children and people's mental health settings in relation to outcome measures. So I'll just share some of the kind of highlights, if you like. So they wanted to take a very implementation science-driven approach to understanding CAMHS practitioners' perspective towards outcome measures, and particularly the barriers of implementing them across settings. So the model, the COM-B model, essentially proposes that interactions between someone's capability, their opportunity and their motivation are the antecedents or the triggers of their behaviour. So in this case here, we're talking about routine outcome measures. Capability refers to an individual's psychological and physical ability. Opportunity refers to the factors that are not attributable to the individual, but they may encompass the context, so the physical and organisational factors. And then lastly, motivation refers to the automatic, habitual and reflective processes and mechanisms that activate or stop that particular behaviour. So reflective processes could include evaluations, making plans, automatic processes involving emotions and impulses. And obviously the COM-B model sits at the centre of something called the behaviour change wheel, which is a toolkit for designing behaviour change interventions. So there's many opportunities to learn from this in outcome measures in young people's mental health settings. I'm not going to go through all the survey responses, but essentially they use the survey to map onto those different components of COM-B, as you can see on the screen. And the key findings and highlights. So they looked at frequent users of outcome measures compared to infrequent users of outcome measures. And compared to infrequent users, those who used routine outcome measures frequently had higher levels of knowledge and skill. So they reported that they were more confident about how to use measures, more able to select measures to help assessment and monitor progress. Interestingly, receiving external training that was perceived as helpful across all training types appeared to be absolutely key and particularly important. And the length of time since most recent training didn't actually differ between groups. So this tells us that actually it could have an enduring effect. Then thinking about opportunity, the key findings that we can see, don't worry about the statistics on the screen, are that the implementation of routine outcome measures, they do not occur in a vacuum, and challenges must be considered through the lens of organisational and leadership structures. So having the opportunity to discuss outcome data in supervision, as we've already heard today, is key, and with young people was an important distinguishing factor between usage groups. Only 16% of infrequent users reported that their organisation displayed information about outcome data, compared to 47% of frequent users. Moving on briefly to motivation, the difference between user groups was particularly salient for automatic and reflective motivations. So that's the internal processes which influence decision-making and behaviours. This suggests that factors such as perceptions about the usefulness of outcome measures, so the perception that service users are happy to complete outcome measures and that there is a strong evidence base for outcome measures, which there is, all play an important role. So in terms of implications from this particular study, barriers to implementation are complex, they are multifaceted across the client, clinician, and organisational levels. And recommendations for practice include things such as integrated multi-level strategies aimed at improving practitioner capabilities and motivations, so perhaps through training, strong organisational leadership and a culture of data gathering, and sharing and interventions and outcome measures at a local and individual level. I just want to share with you through my passion of kind of implementation science and how we should within improvement of our services, another model, which is an implementation drivers model from Fixon and Blase. This is the 2008 version, and how we can use examples of implementation models such as this, looking at particular drivers to map on to what we might need to do to improve the collection of outcome measures. So I won't go through this in detail, and I'm sure you can either request a copy of the slides afterwards, but this is really important to think about those drivers. All of those drivers need to be in place for implementation of something to be successful. So if we apply that to outcome measure collection in young people's mental health settings, we can start to break down the things that we need to put into place. And many of those things, as you can see on the slide, are things that psychological professions can facilitate. And just lastly, in talking about the role of psychological professions, these are things that we can do, whether you're a children's wellbeing practitioner, an education mental health practitioner, a psychological therapist, a child and adolescent psychotherapist, a clinical psychologist. These are all things that we should be doing now to improve the collection of outcome measures within young people's mental health settings. So training is absolutely key. Our supervision and the use of outcome measures in supervision. We are essential to changing culture and essential to clinical leadership within services, and that will further improve motivation and infuse others. Be proud of what we do. Be proud of the collection and integration of outcome measures in our treatment planning and clinical sessions. Hold our services to account. Hold our leaders to account if we're not integrating outcome measures as effectively and productively as we should be. Draw upon our own training, draw upon the evidence base and the research, which we're uniquely placed to do. Facilitate routine outcome measures feedback at individual and team level. And most importantly, really think about how we can influence, champion, and model the use and clinical integration of outcome measures in young people's mental health settings. It's now really important that we learn also from what's been happening regionally in IAPT services to help us and give us some clues. So I'm going to hand over to Maggie now to talk us through that.
Thank you so much, Tim. I know that you made particular time to come and speak with us today, so thank you very much for that. So I'm going to whiz through these slides as quickly as I can, and then I can see there have been lots of questions for Paul, so let's make sure we have some time for that. So looking at this graph, earlier you heard David Clark talking about the importance of getting measures for certain disorders. Particularly for us, These specific measures of anxiety disorders, for example, social anxiety disorder, and we call them anxiety disorder specific measures. We want to collect them at the start of treatment and then as treatment progresses. At a minimum, we want to have 2 sets of scores, as Alison talked about, so that we can see if our treatment is being helpful. This graph shows the completion rates for paired sets of questionnaires over time for the 3 IAPT services in my trust, i.e. have we managed to get at least a first and then second set of questionnaires? This is important because it allows our services and our clinicians to see how helpful our treatment is for our clients. Are we helping them with their particular problems towards their particular goals? So let me talk about the graph. Firstly, you can see the horizontal black dotted line. This is our target. So to have 2 sets of scores for at least 65% of all clients discharged from treatment with a particular anxiety disorder. And you can see what's happened over time. Prior to Q3 2019-2020, we were well below the target. Then you can see that our performance dramatically improved. And from June 2020, all services have been consistently above the target. So what changed? We worked hard with our staff teams to promote a clinical rationale for gathering paired measures. We stressed the importance of these measures for excellent and effective treatment. We trained our staff in the use of measures as a clinical tool, as Emma has demonstrated, so that they had meaning. We invited risk advocates like David to speak at our Sharing Excellence conference. Concerns, for example, that our recovery rate would fall, it hasn't, and myths, for example, that clients wouldn't want these measures. We encouraged all team members to be part of the discussions, and our senior team watched the data and flagged concerns immediately. We've chosen continuous professional development that reinforces our messages around how clinically useful these measures are. We work with our clients around their expectations for completion and how they can make use of measures to aid their progress. We made sure that clinicians encouraged clients to complete their measures ahead of sessions, as you've heard discussed, so that the most could be made of session time. A key factor in our improved performance has been the changes to systems and processes that have happened over time. Those of you familiar with IAPT know that we have a patient record system that has been set up precisely to capture information on service activity and outcomes. I really cannot stress how helpful this is. We've really striven to make the most of what this system can do for us. We ensure that we collect data for each client every session so that our data completeness is there even when people drop out. The front page of the electronic patient record tells us clearly what problem the client is coming for help with, the problem descriptor. This also tells us which corresponding questionnaire needs to be given. We can see clearly where there's a gap in information, meaning a client may be missing out on a measure. The problem descriptor is given by the client. This automatically triggers the right questionnaire for the problem, and this must be completed in order for a clinical contact to be recognised. So for clinicians, you have to take an active step to avoid completing a measure. Clients are encouraged to access and submit their questionnaires ahead of the session via the online patient portal, by computer or phone or tablet. This means we don't have to rely on clinician memory to give the questionnaire and clients to return it. In addition, our trust data analysis systems allow us to monitor our own data completion rates live and respond accordingly. Finally, there's across-the-board socialisation to the use of measures in IAPT, for example, in our university courses from the point of being a trainee onwards. These are the ideas that we've generated when seeking to understand the improvements in our measure collection. Special thanks go to my colleague, Peggy Postma, and to our teams for help in this. So this is the end of our presentations. Thank you to all our presenters. Hopefully this has given you a feel for the importance of measures and how we can benefit from them at a client or patient level, a clinician level, a service level, and a national level. We have probably 5 minutes left for some of your questions. Sorry we can't address them all. Many thanks for your contribution. I'm going to go straight to Paul, if I may. And look at this question which came in. Thank you for sharing, Paul. Do you feel that you've ever scored these questionnaires in a way to please a therapist and not reflective of how you felt?
I think I've scored them to please the therapist and in the dishonest belief that I was going to get better if the scores came down. I think for me, very, very much at the start, I think the explanation wasn't given to me how that I could use them. And the first ever session I remember back in 2009, so 12 years ago, my psychologist said, "Wow, that's the highest score I've ever seen." And I thought, oh, bloody hell, what's wrong with me? And I had a really good therapeutic relationship with her afterwards, but it stuck with me. It really has. And then I thought, well, okay, I'll just get the scores down. I was still working as a detective at the time, so I'd got a lot of outside pressures as well. To get back to work, to do what I should have done. So I think the honesty with that was, well, I've got to get back into working, so I've got to be released from a therapy because the first psychologist was employed by the police, even though it was confidential. So I think, the answer is yes on both scores to please the therapist, because I thought I wasn't probably getting as well as quickly as I should. But also, I guess, to break that stigma. I'm a 6-foot rugby playing ex-detective at the end of the day. So that stigma was massive, massive for me. So I had to get better, which is why I love to stand up now and to say, you know what, guys, you can use these, you can get better. But I'm proud to also say that I have just entered therapy again. Some 5 years since my last one, because of some intrusive thoughts that have come back because of my PTSD. What the scores have made me realise, once I've spoken to my therapist about them, is actually certain areas of my life, I've got those tools that I can use to make my life so fulfilling, and those scores reflect that, because my feelings are, well, actually, I feel quite good most of the time. But I've got these flashbacks, these intrusive thoughts, the night sweats, the terrors. But that's a separate part of it, so I can put that to one side, and I can still take positives out of the other areas of my life that I'm still being successful in. And interestingly, the scores reflect that.
Paul, I'm sorry, I could listen to you all day, as I'm sure all of us are, and I can see in the chat that people really love to hear your story and to hear you talking. Thank you so much. I think we're going to have to close there. I know that all of our speakers have said that they're really happy to be contacted separately, and I think we'll have to work out a way to do that. Probably I'll ask the PPN team to put something on the website about how people can be contacted. I think that will be the simplest way to do that. It just remains for me to say thank you so much to all of our speakers, and thank you so much for our audience for your contributions. Thank you, Paul, Emma, Alison, Tim, thank you. And also to Alina, who's done the moderating in the background with the questions. Thank you. And to the First Sight Media team and our signers, thank you very much to everybody. Matt, shall we move on to our final screen? So this has been our Transform and Innovate session. Paul, did you want to say anything in the last seconds?
No, just thank you for the opportunity for someone with lived experience to be a co-producer of this, and I truly feel honoured that we have co-produced, and thank you, Maggie, for all your hard work.
It's been great, hasn't it? Really good. Could I have the next slide, please? So if you like the sound of our commitments, do tell us what you think. Use the hashtags there. Next slide, please. Okay, so 3 evaluation questions have just been inputted into the Slido window. Before you go, please submit your feedback by clicking the option that you prefer and hitting submit. To download your certificate of attendance for this session, please click the button underneath the stream window. Please make sure you download your certificate before you leave. Thank you very much for joining us today. It's been lovely to see you.